Okay. Good afternoon. I am extremely excited to welcome you to a really special Paragon event, an event that I have been looking forward to for the last several weeks. I am Brian Blaze, founder and president of Paragon Health Institute. Paragon has been around about 4 years now, and we are dedicated to evaluating how government health programs are working and making recommendations that are consistent with principles of expanding patient empowerment, market competition, and ensuring a regulatory climate that is conducive for innovation and entrepreneurship. Today's event, Directing Medicare, Past, Present, and Future, features a conversation between the current director of the Center for Medicare, Chris Klomp, and the director for the Center for Medicare from 2017 to 2021 under President Trump's first term, Paragon's Demetrios Kouzoukas. In addition to being the director of Medicare, Chris is also the deputy administrator at CMS and a senior advisor to HHS Secretary Robert F. Kennedy Jr. Chris has deep experience in healthcare payment reform and data interoperability. He previously founded and led Collective Medical, the nation's largest real-time care collaboration network, and has worked across state and federal government and healthcare startups to advance value-based care and technology-enabled reform. Demetrios Kouzoukas is the director of Paragon's Medicare Reform Initiative. In his role, heading the Center for Medicare, Demetrios led sweeping reforms that lowered payment errors, reduced Medicare Advantage premiums, expanded telehealth, advanced price transparency, and modernized payment systems across Medicare, including skilled nursing and home health. Today's event is being recorded. When it's ready, the video will be shared on our website and YouTube channel. I encourage you to go to paragoninstitute.org. There's a button on the top right for newsletter. If you're not a subscriber for our newsletter, you can sign up, and that's where you'll get our weekly policy and research updates. Okay, Chris and Demetrius, thanks again for participating. Chris, we're really excited to host you. I think you're doing tremendous work at CMS, and we look forward to the conversation. And I'm going to turn it over to Demetrius. Thank you.
Thank you, Brian, for the introduction. Thank you, Chris, for participating in this, and to our audience for tuning in and listening to our conversation. This is something I've also been looking forward to. It's not often you get to talk to someone that you shared a job with, and this is a job that, at least in my view, is so demanding and so intense that even before I first met Chris, I felt like we were connected, just knowing that he had the same role and responsibility. And it's been delightful to get to know him and work with him as he improves on the work that I managed to do when I was there as well. Chris, thinking about the job and talking about the job, what was most surprising to you about this role of running the Medicare program?
Well, Demetrius, first, thanks for having me. I've been excited and looking forward to this conversation as well. Second, I feel the kinship you're talking about. Uh, I'm also a little nervous today. I feel like I might get a real-time grade report or scorecard from you, and someone who's legitimately qualified to offer it. So we'll see how this conversation goes. Most surprising thing about the job, unquestionably, that CMS reads all the comments. I wondered that for years. And I'm like, how could they possibly go through all of that? You know, if I write this letter to CMS through the notice of proposed rulemaking, will they really read it? Or is it a tree falling and no one's there to listen? And it turns out we actually read all the comments and pay attention to them and discuss them. Um, that's more tongue in cheek, but it is true. I'd also say surprising, pleasant, confirmation, affirmation, otherwise, the career staff at CMS are incredible. And I've had the privilege of seeing that up front and personal. And gosh, I wish every American could have the privilege that's been mine over the past, nearly year to experience what I've experienced, to see the career team, our career civil servants in action. These are extraordinary individuals. They love their country. They love these programs. They are deeply knowledgeable. They are dedicated. They work long and hard hours in what is often a thankless job. Uh, Most of them could easily jump ship at any point in time, and I'm sure make far more money in the private market, and yet they choose to be here and serve. And it is incredibly inspiring. And I think if people could see what I see, two things would happen. One, the American people would have a little more hope in their government than they do already. And two, they probably criticize our career civil servants a little less than they do. You certainly won't hear me criticizing them on a go forward basis. To the contrary, I feel the need to vociferously defend them. They're incredible. And that has been one of the most pleasant surprises in taking the job.
Chris, I have to say, I feel the same about the relationship and the partnership with the career staff at CMS. And it's been my experience 2 times serving in government now. I remember a mentor telling me when I remarked to him that I was going to go when I come back to government, I was really going to focus on just a few things and not worry so much about the management issues because I had limited time. And he said that was wrongheaded, and that in fact you need to pay attention to the management issues. You need to work just as you do with any team in any kind of large, you know, organization and environment to inspire them. And that I had done so in my previous work, and that he encouraged me to keep doing that in the second time, and I did. And as a result, I think looking back, I say that you move mountains from the bottom, not from the top. And that means that you have to, whether or not people agree with you or not, if they understand where the direction you're going in and they understand why, they can do their jobs a lot better. And so I always took the time and effort to both focus on the management issues and to explain where we were going and why.
I think that's incredibly wise, and I appreciate that counsel. I agree with everything you just said. I'd also say that healthcare might be that rarest of issue sets where both sides of the aisle, red, blue, left, right, center, have much more in common and the space to agree than not. And certainly my experience with our career team has been that they have the right answers. They know what needs to be done. And often it's people like us who have been sitting in this seat who, for a variety of reasons, political or otherwise, might prevent them from doing those things that they know will solve the problems that we're observing in the market. And so
Hmm.
maybe showing up with a modicum of humility and asking more questions than proffering responses and statements and strongly held opinions might actually lead to better outcomes. And at least that's been my experience. They've been incredibly kind and patient with me. They teach me, they bring me along, and they listen. And while I have no idea what side of the aisle any given person is on, I would say the vast majority of our team is highly aligned against the plan that we are attacking right now at CMS and at the Center for Medicare in particular, because we all believe in it. We all believe it's the right thing, and so we're sprinting toward it.
I have to say that I searched for quite hard to find an end to the patients for many questions that I had, and didn't find the end. So definitely echo that in my experience as well.
I got to tell you, hearing you say that makes me feel a little better because you are so knowledgeable on all things healthcare policy, and you had that advantage over me coming into the role. I feel like I understand the business of healthcare pretty well and have a pretty good sense of how it works across Medicare, Medicaid, commercial markets. But I'm not a policy expert, and I don't come from this. This is my first government service. And so, certainly, particularly for the first 90 days, but ongoing in continuation, I felt like I was learning another language, and it was exhausting. And I had to put in that many more hours. I'd see my family Sunday night, and I probably wouldn't see them again until Friday night or Saturday morning. And it was in early and home particularly late, just doing homework and translating and trying to understand this language that was being spoken, even though it was all about this thing that I had a pretty strong understanding of. And they were right there. The career team was right there and has been and continues to be right there with me, gently saying, "Hey, what if we gave you a little background or a little 101 on this one? Or would it be helpful if we did this?" Or they wouldn't even ask, they would just do the thing. Uh, they're incredible. I have so much gratitude for them.
Well, speaking of learning to speak Medicare policy, which is its own language, as you did that the first year and you look back now as you start the second year, What are the biggest accomplishments for the Medicare program in 2025?
Yeah. So first, let me give you a meta-level answer to that question. I think one of the biggest accomplishments is using all of the tools at our disposal, and you have seen this. And I'll rattle through some specific things to actually understand your or answer your question. But as government has the power to legislate, and that's a lot of power. But things don't always turn out exactly the way you expect them to. It can be a little unpredictable, and we obviously within the agency have the power to regulate that can take a long time. And if somebody doesn't like what you are trying to accomplish in your rulemaking, lawsuits tend to flow freely, and they can really slow you down. And then we also have this third power that I think is highly underutilized, at least until this president, who wields it exceptionally effectively, which is the power to convene. It turns out that I'll speak for CMS in particular, can play an extraordinary role in bringing parties together who may actually agree and don't even realize it, but where there's a trust deficit, and find common ground to accomplish a set of objectives by conforming individual self-interest with the public's social interest. And in that process, we can go faster, we can accomplish our policy objectives more quickly, and I would argue with a greater degree of predictability. If I pass a law or we institute a rule that you don't like, you as the private sector will use your considerable resources to try to navigate around it. But if I have a pretty good sense of what your incentives are, and we can come up with a framework through the power of convening with a high degree of predictability, I know where you're going to land, and I can design a system around that. And so we do that a lot. I can give you some examples. In terms of biggest accomplishments for 2025, as you've seen, it's been a sprint. Dr. Oz is extraordinary. The president has empowered him. The secretary has empowered him. He's built a team that is willing to run through brick walls for him. And I would argue even more importantly for one another. We get along, we like each other, we trust each other, and we work together massively, not only in breaking down silos, but trying to shift healthcare forward. And so many of the things I'll talk about might not sound like they're Medicare specific, and that's because they're not. We didn't try to solve prior authorization for Medicare only in Medicare Advantage. We want to solve that for the whole market. And so we think about the broad set of tools at our disposal across centers. We're looking at Dan Brillman and Caprice Knapp in Medicaid. We're looking at Abe Sutton in CMMI. Peter Nelson in CISIO. What can we do in Medicare? What other tools do we have available in order to accomplish things? And so I'd break those accomplishments into several buckets. And this is certainly not a comprehensive list, but it'll give you a flavor. From a financial perspective, we strengthened the trust fund further in 2025, and we tried to promote value in original Medicare by standardizing payments across sites of care, so-called site neutral policy. We worked to rein in sharp increases in low value care spending, things like the skin substitute industry that saved, we estimate over $20 billion a year. We worked to adjust payments to recognize efficiencies in healthcare delivery and to try and create incentives to drive more efficiencies there. I dare mention, through the IRA, we negotiated more drugs. This time it was a hard, real $8.5 billion of savings compared to 2024, resulting in about a 36% aggregate discount across the 15 drugs selected for negotiation for 2027. That's on the financial side. There's more. On the clinical and quality side, we set the foundation for future efforts to strengthen primary care with improvements to the APCMs, the Advanced Primary Care Management services, and extending critical telehealth flexibilities in the short term while making permanent important telehealth flexibilities and supervising physicians in training. Why does this matter? We've talked for a long time about the fact that sick care is more expensive than well care, but you have to make investments up front. That's harder to do in a budget neutral construct. Definitionally, that can be zero sum. Doesn't have to be, but it can be. So we took money, from select specialty care and we invested it in preventive care through primary care because we know that's the right thing to do over the long term for the country. That's not without consternation and some frustration by counterparties, and I acknowledge that. Building on clinical and quality, we shared savings program. We continued to transition to digital quality measures. We're focused on electronic reporting of those. SSP is continuing to outperform comparable physician organizations on core clinical quality areas. You've got something like hypertension control that's north of 71% versus 68% elsewhere. Depression screening and follow-up, 53% versus 44%. Patient experience of care. You go rattle down all these different metrics. You see that in an accountable relationship, we have better quality. When we have better quality, you have happier beneficiaries, more productive beneficiaries, and it turns out it costs you less. So that kind of gives you a summary on clinical and quality. We focused on program operations. How do we improve quality? How do we improve access with MA and Part D plans? Streamlining stars from a quality measure perspective in 2027 MA and Part D proposed rule. Patient experience, we're focused on that. Commitments in for major insurers around prior authorization. Voluntary commitments covering more than 80% of Americans now in insured lives with a set goal with industry that by 1/1/27, 80% or more of any codes remaining that require prior authorization would be adjudicated in real time in the provider's office while the patient is still there. Number one complaint of patient and providers alike. And then, of course, MFN, most favored nation policy by the president on drug pricing, which we can talk about, but has been an extraordinary success. I'll pause there.
I'd like to talk about that. It's a different capacity or tool that you're talking about here, these deals or negotiations or convening, if you will. And certainly understand the opportunity it provides to advance an agenda. What about the precedent it sets, though, for others who may not share the same policy views or goals and maybe just as passionately take this up in the future and in a way that might be perceived as coercive or not transparent or inconsistent? And, is this method of making change one that's sustainable and permanent? And how would you address those concerns about the precedent it sets?
Sure. So to me, adverse precedent is when you regulate against the wishes of the public. And then we could include wishes of the stakeholders whom you're regulating. That's probably a worse precedent because when we harden, we codify something that people don't want, maybe the American people don't want. It would be akin to not using market forces, which I strongly believe in free market enterprise principles to achieve a given objective, as though we know better, as though centrally planned systems might be better. And I think for a variety of reasons, we're learning that that is not the case. Let me give you two examples of why I think that I'm less concerned about the precedent, and rather, I think it's a positive precedent that government should do more of. And I believe in what the president is trying to accomplish. Let's choose prior authorization. A misinterpretation of what happened with prior authorization, what I just referenced. There were 6 commitments by industry, voluntary commitments by the plans to streamline the measures that require prior authorization, to streamline the process and increase the transparency of prior authorization itself, and then to speed up that process and use electronic enablement to reduce the burden on providers and speed up the process for patients again. The initial response from some who were less informed assumed that we wrangled all our payers in a room and we thumped on them and threatened them in order to get this done on behalf of patients and providers. And that might have been a fine optical approach, but that was in fact
Just in the room.
It turns out that the CEOs of every major payer also don't like running around, after Brian's murder with security details and getting beaten up over prior authorization for denying care. And it turns out that making a float on the premiums that they've collected but not yet paid out in claims, while beneficial to the bottom line, is not actually that substantial in moving things forward relative to the cost of misusing prior authorization as a utilization management technique. Providers wouldn't believe that and didn't believe that, and there's great mistrust. And similarly, there's mistrust by the payers of the providers that if left unchecked and you eliminated prior authorization, costs would run rampant. And there's probably some truth to both. And so the role for CMS to come in was to align incentives. In this instance, it turns out the payers had already been considering this and wanting to make progress, to use other utilization management techniques like gold carding, for example, which exists in virtually every other form of insurance other than US healthcare, and can be a powerful, and it's not the only way, but a powerful utilization management tool to ensure not just that the appropriate care from an expense perspective is being rendered, but that the appropriate clinical care is being rendered for the best outcome and the health of the patient. It turns out the providers really want this as well. They didn't sign up to have to go fight with the insurance companies. And the patients really want this because the last thing you want when your doc says, gosh, you've got an unknown mass, we better get a CT scan. Let's get that ordered. I just ordered it for you. Oh, wait, you're going to have to wait. Why do I have to wait, doc? Are they busy? No, your insurance company hasn't approved it yet. In that moment of greatest uncertainty, that's the worst time to have prior authorization strike. And so all three stakeholders in this thing actually wanted the same thing. How do we ensure the appropriate utilization of care? Why do we care about that? Patients care about that as well, because if we don't, everybody pays more. Why do we want it for providers? They want to render the right care and they want to render care. They don't want to be navigating payers. Why do the payers want it? Because they're charged with being the appropriate stewards of care. And it turns out they need healthier beneficiaries as well. And so we played a trust deficit role, or complementing a trust deficit to bring them together and to try to drive alignment. Turns out we could do that far more effectively across commercial Medicare and Medicaid than we ever could have with our regulatory tools that we had at hand. And it is difficult to rely on legislation to accomplish the same objective. Let me shift to MFN as another example. There is no question when the president first announced his objectives around most favored nation and drug pricing that there was wailing and gnashing of teeth and consternation from industry. Let's lay out the facts. The United States funds 50% of global research and development for branded pharmaceuticals. We're about 60% of revenues and about 65% of profits. Yet we're 4% of the population of the world. And on average, relative to just the wealthy world, this is UK, Germany, Switzerland, Japan, for example, we pay 3 times, about 2.8 times more for the same drug, same box, same manufacturer, same plant. It's not fair. And the president liked that. He called for fairness. He didn't ask us to get a better deal. He just wanted us to be fair, have everybody pay a little more, have us pay a little bit less. That was an interesting exercise. We didn't have a lot of statutory authorities to achieve that objective. And so we defaulted to the power of convening. And for a while, there was resistance for a variety of reasons. Would we go too far? Would we abuse the strength of the US federal government? A sovereign versus an individual company. That doesn't seem like a fair fight. Over time, as trust was built with the CEOs of these companies, several interesting things occurred. Number one, they said, well, actually, we would like the system to change. We don't want to have 65% of our profits coming from a single customer. That's actually not great. We'd like a diversified base. Number two, most of them are American, and they also don't think it's fair. Number three, good people tend to go into healthcare. I'm pretty convinced that bad people don't. But sometimes the pressure to perform obscures priorities and people lose their way, and you have to remind them why they got there. Most people who work for pharmaceutical companies, and I do genuinely believe this, got into that work because they want to save lives. They believe in the science. They understand that there are roughly 25,000 known diseases in the world, and we have at best a treatment, sometimes a cure, for about a quarter of them. And that leads to human suffering, and there's an opportunity to alleviate that human suffering. So when you started to remind these CEOs why they were there and what this meant and what their legacy was for their children and their grandchildren, and maybe that there was an opportunity with a rational, objective counterparty in the form of the president and his administration, that we just might be able to rewire global drug pricing and do so in an orderly manner that at the same time didn't compromise innovation and access to these life-saving medications. So fast forward that. Is it enduring? Well, I think it is. Why is it enduring? The president wants to codify this as part of his great healthcare plan. But here's why I think it's enduring. Because the economic incentives are aligned. Right now, you have about 8% of drugs that come to market on patent each year. And about 8% roughly fall off. So over the course of 12 or 13 years, every new drug, when committed to come in at MFN, will now be priced in MFN. In the meantime, we had provisions around Medicaid now to move those portfolios into MFN, to launch Trump RX and the direct-to-consumer model, which we hope over time will be adopted by insurers as well to drive transparency and cut out unnecessary intermediary extraneous fees. And the ability that as trade levers work in other countries and additional revenue that otherwise could not have been captured is realized, a portion of that goes back to offset prices in the United States, all of which is accomplished without a price cap. You're free as an American manufacturer, any other manufacturer has entered into a deal to price wherever you want. You launch in the United States in the first place anyway. The only ask is don't undercut us somewhere else. That's a powerful construct. you saw the share prices of those manufacturers rise. I think that was in one part because the market was worried, and this gave stability and certainty. Markets can handle good news and bad news, they can't handle uncertainty. But the second point I think that is more interesting is that you actually see additional revenue opportunity to drive additional innovation to solve for additional innovative medicines to save lives coming from other countries. The day after the first MFN deal with Pfizer was announced, we started negotiating alongside our colleagues at the U.S. Trade Representative's Office, Ambassador Greer, and our colleagues at Commerce under Secretary Lutnick's leadership with the United Kingdom. And in 59 days, achieved an agreement in principle for the United Kingdom to increase what they spend on branded pharmaceuticals for the first time in 26 years. That's the power of convening. When the market unites around a common goal, we shifted. It's no longer a company versus a sovereign. It's the entire Western pharmaceutical industry versus a sovereign, asking the sovereign to fairly value life-saving innovation in the same way that we do in the United States. And in the process, prices come down here, as you have seen in the announcements from the Oval, and as you will see on Trump RX, and over time across various lines of business. And we haven't cannibalized innovation or access in the process. It would have been very difficult to land that plane through regulation and certainly through legislation in the same way. But it turns out we were able to align incentives. It requires trust as an intermediary counterparty, and that is the role that we played.
It's a fascinating story. Thank you for sharing it and putting us in the room. Speaking of prices and not necessarily drug prices, but one of the things that was noticeable about the efforts undertaken in 2025 was the effort to restore a rule from the first Trump administration to make the relative valuation, if you will, or the relative resources allocated to different things in inpatient hospitals based on market-based prices. And it kind of brings to mind a bit of a question that I got often when I was in the role, which is, I mean, every week, every day, really, I'd get someone saying, well, does Medicare pay too much for this? Does it pay too little? Do you get that question? How do you answer it?
Yeah, the answer we get the question constantly. We ask the question of ourselves constantly, and is a woefully underwhelming answer, which is, I don't know. I mean, did you know the answer to it?
No, I think that was usually my answer, and it would befuddle people. It kind of made people feel like I wasn't doing my job sometimes because I couldn't tell them if we pay too much or too little. But the fact was that we in Medicare decide how much to pay based on a complicated set of formulas that often really relate back to costs and costs that are accounted for in the most kind of strange form of accounting principles that you can think of, and then are put through this kind of machine and outspits the prices. And it doesn't really tell you what the real price is. But because Medicare has such a big impact, you don't really know what a willing buyer or a willing seller will pay for it, because the power to spend essentially has its own inertia, and people follow the Medicare prices. And so the market-based sort of looking to the market to decide how much Medicare pays is such a fascinating concept. And we worked on it in the first administration, and delighted to see that you put it back. And I was wondering, are there other instances where you think similar principles can be taken, or approaches, and ultimately, help answer these questions?
Well, I got to tell you, one, Demetrius, you better watch out. You're sound like a free markets guy. So, you better watch yourself. Two, you're making me feel better about myself and not having the answer. I don't know if we underpay or we overpay. It's hard to know. That's part of the problem with essentially planned healthcare economy. We're the largest rate setter of medical care on the planet. And as you know, where Medicare goes, so too does most of the rest of the market. We are the rate, policy, and benchmark setting engine for US healthcare, probably an 80% flow through. And so that's a little scary as we get bigger and bigger and bigger. And we know this is an issue. This is not a novel concept. Value-based care is something that's been talked about for 20 years. I'm not sure that's the right name. I think we've fatigued of that. I certainly have. But I also don't think we should throw the baby out with the bathwater. There are reasons why it has not been particularly effective. One of which is that we at Medicare continue to propagate a system of centrally planned rate setting and policy setting. But it's difficult to respond fast enough to the idiosyncrasies of the market. And it's difficult to tie that to value. There's some things happening that are extraordinary, and I'll talk about those in a second. But generally speaking, There are very few industries in the country, in our economy, where we are willing to pay for an input. I don't go to the restaurant and pay you because you attempted to make a meal, but you failed, and you come out to my table and say, sorry, it didn't really work out, but here's your bill. I paid for a meal. I want it to taste good, and I'm paying you for that and the service that comes with it. Why don't we do that in healthcare? I mean, it sounds absurd when I say it out loud, and yet we don't generally do that. And then we're sitting wondering, well, why aren't we getting the outcomes we want? And if you step back, you say, okay, well, healthcare is what, roughly 18% of GDP. We're spending $15,000 per capita, going to 21,000 inside the decade. It grows about 300 basis points faster than GDP does. That's a scary statistic. And oh, by the way, not only are we paying the most we've ever paid for healthcare, but arguably we're the sickest we've ever been. You get 70%, 65% chronic disease rate, 45% polychronic rate, 30, 35% emergent and diabetic rate. That seems problematic. And so maybe we should think about doing things a little bit differently, and maybe we should start to pay for outcomes more consistently. And I think that's the opportunity. And so let's give a couple examples of things on our mind as it comes to this. We like market-based pricing. The market is pretty good. You referenced that. What is the economic definition of a market? You already said the first point. You have a willing buyer and seller. The second point, the buyer knows what they're buying. I grew up in Idaho. That's potato country. It's not lost on me that we can ship potatoes any in the world, and there doesn't have to be somebody who shows up ahead of time to inspect those potatoes because there's a grading system and it's very clear. And the buyer knows, okay, I know what the size is, I know what the quality is, I know what the type is. Here's what it's worth to me. And then there's price discovery, which is implicit in that. So I know what the quality is and I know what the price is. And we largely are still missing those two ingredients in healthcare. And we're making strides. You started on the price transparency stuff in your own work. We're trying to build on the foundation you already laid for us. We're trying to do the same thing on quality measures. We collect all of this data and we collect, kind of volumes of quality metrics, but are we equipping beneficiaries? Are we equipping patients at the point of care when they're going to make a decision to understand, well, here's what you're getting. You've got surgeon A, you've got surgeon B. Here's how they perform on the thing that you probably need, and here's what it costs. Make an informed decision. That's a market. And so we need market prices. We need market transactions because when you do, one of two things happens. I get fat and happy as a provider, in which case I go out of business because I'm not delivering good quality relative to the cost that I'm charging for it, and somebody else is, and the market goes there, or the other way around. Now, I realize, and I'm not naive to this, we can't fully treat healthcare like a market because markets also have supply and demand curves that price to the marginal point of intersection. And in healthcare, I strongly believe that I am my brother's keeper, and we do have an obligation to provide care for every American, and we have a responsibility to ensure that as a country we live to our full potential, which means helping our individuals do the same, which means helping them be healthy, because it's hard to meet your potential when you're not healthy. I've said this before. So how do we do that? You've referenced it. I'd be curious your thoughts on market-based DRGs, for example. Are they actually circular? Or is there value? I'd argue there's a lot of value. Maybe we debate that. Similarly, Abe Sutton, Jacob Schiff out of CMI just launched the Access model. It's a technology-focused model, but it's beautiful and it stands apart in two particular areas that I love. Number one, it pays for outcomes. And number two, it sets prices in such a way that you have to innovate. You can't keep doing things the way that you do them today. It rewards folks who find the way to do something better in order to achieve that outcome that the patient wants, that we want, and then it compensates them accordingly. It's not a fee schedule. It's not a fixed rate. It's not set centrally by us in the first place. That's powerful, and that's a powerful step toward market-based pricing. But I'd flip it back to you. Maybe, if you're willing, what are your thoughts on market-based DRGs, for example, and their implied circularity? Is that a fool's errand?
First, I'd say if they're circular, they must be harmless. There won't be much of if there's not much of an impact. And I would say that in terms of the vision that you described, which is, I think, wonderful about how we meet our country's needs and individuals' needs using competition and choice and harnessing it, we want to see exactly that kind of system. The way that I talked about it when I was in the role was that I want to see every Medicare beneficiary their business, their loyalty be the subject of intense competition. That and every consumer doesn't need to be a shopper. It could be just a subset that really end up driving the difference. And so that's kind of the big picture goal. Getting there has two parts. One is undoing some of the things that this inevitably happen as a result of making prices essentially through, government central planning, like you described, or price setting. And so that's how you get things like skin substitutes that would have resulted in another $132 per year for every Medicare beneficiary next year if something hadn't been done.
That's a perfect example, by the way. Can we pause on that one? Why is it that Medicare itself, original Medicare, was paying what we were paying in skin substitutes, but the plans, the MA plans, who had that market choice weren't? That's
Yeah,
interesting.
inevitably, and I would say even if you had the foresight, no matter how smart the people at CMS are, no matter how benevolent and helpful and well-minded the leadership is, you're never going to sort of proactively identify and manage these kinds of distortions
That's
that
right.
come
That's a
up.
Sicilian task.
Yeah.
That's right.
So there's going to be a certain and site neutrality is another one, and there's more to do on site neutrality. I hope you share that sentiment as well. You got a great start last year, but there's a lot more that can be done around services that are done in multiple settings, and some of the ways that past congressional actions have been interpreted in a way that allows continued arbitrage over the sites, notwithstanding Congress's attempt to limit it, and also enabling sites that are more efficient of care, like ASCs, to compete with with outpatient hospital settings. So there's a whole category of things that are about sort of eliminating the distortions and trying to fix them. But there's another category, which is, well, what do we replace it with? And that's where this market-based DRG concept comes in. And it has application, I think, not just to the hospital payment system, for which it's been reinstituted thanks to your work and leadership, but also in other areas like possibly Medicare coverage or many calculations, for example, inside the physician fee schedule. There might be numbers or figures or calculations that could be done with market-based data instead of government-driven data. And so we've got to start somewhere. And if it is circular, it's either harmless or it's a good start. And as we eliminate distortions, we also have to work just as hard to build a platform for the future to achieve the vision that you, I think, painted so nicely.
Well, I appreciate it. I agree with your assessment on market-based DRGs, by the way. I was just chatting about this with Joe Albanese, who leads policy for Medicare. One of your former colleagues at Paragon, who's extraordinary and brilliant. And I think that the key insights here are it's not just that we're going to start referring to MA prices and they refer to ours and nothing changes. That's the circularity argument. I reject that argument. I don't think that's particularly logical. I think the goal is that we want to give private payers in the Medicare Advantage space the incentive to drive value through their own contract negotiations instead of always referring back to Medicare prices and then tacking on a cost plus percent. We want them to dig into the relative valuation and determine if that valuation is correct or incorrect, gradually, predictably, by the way. But the whole point of having a private payer play the role of ensuring value is so that they can ensure value is actually delivered in the market. So you have to allow them to do that. And over time, if you allow for the conditions in the market to arise, so the innovator players can gradually deviate from where there is a difference between what original Medicare pays and what the actual value is in the market, guess what? Prices adjust. We pay for outcomes. That sounds a lot like a market-based pricing regime. And in the process, then we, CMS, for original Medicare, can look at that data. We can carefully, gradually analyze it thoughtfully. We can consider our observations and then potentially begin to make policy, of course, running through a notice of proposed rule and comment making, so that we ourselves can also become a better payer, so long as we are also still centrally planning fee for service or Medicare. So I'm a believer in this construct. It should be done with stability and predictability in mind.
I think you're preaching to the choir. And speaking of private payers and the intersection with Medicare, noticed that recently the that the Health Affairs Scholar publication
Yeah.
has an online draft, and I'll say the whole title. It's a mouthful, but in case people want to look it up, it's called an updated
Blame
analysis
Joe Albanese.
for the title. I won't blame Joe for anything.
I give him
Uh,
credit for everything. He's extraordinary.
so
Joe and
it's
Alec Armanda are incredible.
yeah, you have
John
a
Brooks
great
as
set of
well.
colleagues there, and the authors, I think, authored by you and Joe and Alec and John Brooks.
Yeah, and they are amazing. They are brilliant, and they're wonderful colleagues.
And I've been lucky to work with them too. So the title is an updated analysis of coding pattern differences in Medicare Advantage, and that's a mouthful. But what it says is it's a very short piece, and it says that looking at just some lags in data and the adoption of the latest risk adjustment model in Medicare, which was done during the last administration, that the coding difference that's been estimated by others between Medicare Advantage and fee for service, so that which was estimated by others to be around 10%, maybe more like 1.5%. So just a really amazing sort of set of conclusions from what is on the surface, a strikingly simple analysis. Is there more to come from CMS and pieces like this? Are there things that you could look at, like spillover, favorable selection, where you might also just pull the curtain back a little bit and give some great insights to the world, the Medicare world?
Yeah. So, of course, coding pattern differentials is something that we are charged statutorily with doing. And so we have years of deep expertise in that area. And of course, we have an informed point of view, as do our colleagues at MedPAC as they educate and advise Congress. Uh, this piece seemed important for us to share our perspective to inform the ongoing debate of coding differentials and cost differentials between original Medicare and Medicare Advantage, because there is an ongoing debate. I would argue that some of that debate is, I think, erroneously framed in that those are two fundamentally different programs. If we actually look at the three forms of Medicare, you have original fee-for-service Medicare, sometimes tacked on with a Medigap plan. You have accountable care in Medicare Shared Savings Program, or a derivative or successor CMMI model, and you have Medicare Advantage. Each offers different benefits and a different experience to the beneficiary. We talk about them as though they are all apples to apples comparatives, when in fact they are not. They're different. And yet we're benchmarking cost accordingly, even though they provide different benefits. And so I think there's a little bit of clarification that's helpful in understanding that from the market. But nevertheless, the ability to inform our perspective in the debate we think is important, and to share that alongside our colleagues at MedPAC as we seek to learn from them as well. But we consider our own insights and analysis when we make policy. And so more transparency and sharing with the market how we are doing things and why we are doing what we're doing seemed prudent and reasonable. And that was the genesis of that article in Health Affairs. You mentioned spillover. That's interesting. Studies suggest that in both MA and ACO, we see a ratchet effect, that the rising tide lifts all boats, helps everyone. This isn't always captured in a neat side-by-side comparison of the programs, even though it's likely there. We have not done as much analysis on favorable selection. MedPAC has done some. We have done some. There's probably opportunity to share some of those insights as well. On favorable selection, similarly, this is a concept that MedPAC and other researchers have raised. There are obviously multiple methodologies. There could be potential policy drivers that come from this. This isn't a concept that's materially driving our own policies yet, but this notion that beneficiaries with lower actual spending relative to their risk scores, or lower risk scores compared to the average beneficiary, may choose an MA plan, could have meaningful implications. It's something that we want to understand, obviously. I can't speak to, what, if, or when, we might share more pieces like Health Affairs, but I will say, generally speaking, I believe in transparent, accountable government. I think this entire administration does. And so the opportunity to inform that debate, to participate in the debate, to receive feedback from the debate that can further improve our policy making seems like a wise and prudent decision.
Thank you for that. So we'll look forward, hopeful, perhaps, to some insights as the situation warrants. Just because it's so fresh and recent, I want to ask a little bit about the advance notice that was issued yesterday
Sure.
for Advantage rates. And there's sort of the issue that's grasped everybody's attention this morning and last night is that there's a requirement essentially that whenever a diagnosis comes from a review of a chart that an MA plan has done, and when that links to data, when that results in links to payment, that it has to be linked back to some previous encounter that's in CMS's system that had been where healthcare encounters are reported by plans. And I'm reminded that when I was in the role, we made a transition from one kind of computer system and sort of extent of information collection that CMS was doing to another. And that transition resulted in an amount of government savings merely by the fact that the computer systems were changing. The data fields were changing. The way the computers talk to each other were changing. So it took several years to work it out. And in the meantime, there were savings to the government because certain submissions weren't accepted because of the need to make the technology work better. If that were to be the result of this change that's been proposed yesterday, if it's adopted, and it ultimately, is it something that you see as creating a long-term saving because you've projected that in a certain savings amount in the advance notice, or, and I'm asking you to speculate a little bit, if in a few years, the technology and the way to link these things together that I said the CMS would be proposing to require be linked together as a technological and process matter, if they can do that better, plans and providers and CMS, then those savings will go away. And if that happened, would you be disappointed, surprised? What would your reaction to that sort of scenario be?
Sure. Well, the short answer is, of course, if we don't see substantive changes in behavior and performance that enable participants within Medicare Advantage to do their best work in serving our beneficiaries while also concurrently being wise stewards of taxpayer dollars, obviously we'd be disappointed. Uh, I want to be clear because obviously much has been made about the advance notice since it was released after market close yesterday, including questions raised. Is the administration not supportive of Medicare Advantage? Or did the market simply misread? Or is this a sign of unfriendliness on hostility to come to the market? We have communicated, I believe, clearly and transparently about this. The administrators communicated clearly and transparently about this, but in no uncertain terms, let me make clear that we continue to believe Medicare Advantage will and must play an important role in the future of Medicare. We are focused on ensuring that it continues to provide excellent value to our beneficiaries, the 68 million beneficiaries whom we're charged to serve. What does that mean? That they have the best possible healthcare experience they can, that they get the care that they need, that it's done cost effectively, that it's the right care so that they can lead their healthiest lives possible, while at the same time ensuring the long-term sustainability and stability of the program. In keeping with those goals, we've proposed some modifications relating to, as you've mentioned, coding for unlinked chart review. What is the goal of that? It is to ensure that program incentives better reward activities that actually improve beneficiary care and the cost
So
effective.
it's not just
Of that
about the
care.
data fields. It's not just about the linking. It's that the linking you think will uh, relates not just to sort of whether or not there was a relationship between the care and the diagnosis. You think that there might be a relationship there. It's not just that you don't think that the data connection isn't flowing right. You think there's more to it.
People talk about the data connection. They talk about home risk assessments, HRAs. They talk about all of these extraneous things. What is the core objective of risk adjustment? You know what it is. It is to ensure, it is nothing more or less than this. Risk adjustment exists. It was put in place by Congress. Why? To ensure or prevent to prevent the adverse selection against beneficiaries who might be sicker, so that MA plans didn't
Cherry picking.
for one reason or another, cherry pick. That's it. We do not want risk adjustment to be a source of competitive advantage. If you're better at it than me because you have more resources than me or more cleverer than me, or you decided to focus all of your attention on doing that really well, perhaps in place of rendering the best possible care to the beneficiary whom you are charged sacredly with stewarding and helping and serving, that is not the point of risk adjustment. And so linking chart review is to drive a specific behavior. What is the behavior that we're looking for? If you find that a beneficiary is sicker, you code something in a diagnosis, we want to see follow-on care that you help get that beneficiary healthier. And I want to be clear, many Medicare Advantage plans do this. That is their goal. That is what they are trying to accomplish. And we love and we cherish them for that. We want to support them in that. We want the entire industry to do that. But in the process, somewhere along the way, over the last several years, there has been a breach of trust. The American people have maybe had a little bit of a lack of confidence that Medicare Advantage and that the government who is overseeing and regulating and stewarding that program are being the wisest stewards possible of that program and of our otherwise scarce taxpayer resources. And so,
That's really helpful, Chris. Because
two
go
objectives:
ahead.
stability in the program, but program integrity and trust in the program. And you must have the latter in order to have a long-term, sustainable, thriving Medicare Advantage program. But that is what we're solving. Make no mistake, let me not mince words in the least. We are massively in support of Medicare Advantage. It is a critical component of the future of Medicare.
That's really helpful. I have been thinking the linking was to a past encounter, but I think you're shedding some new light on it for me, which is you're looking for a link to a past or future encounter, but particularly focused on the future encounters.
Because we
Uh,
want a link to care.
I gotcha.
We're paying you more to take on and insure a sicker beneficiary so that you will render more care to them so that they will be healthier and live their full potential. That is what we're solving for in risk adjustment. We want you to compete in the open market against anyone else who participates in Medicare Advantage or in ACOs through shared savings or not in any of those programs. But I mean it. We want you to compete so that beneficiaries have choice and they choose the best possible care from the best insurers and the best providers at the most reasonable cost. Because we know that when you have market forces in competition, that improves the consumer experience. I have to compete or I go out of business. That is the principle underlying everything that we are doing here, nothing more or less. The rest of the advance notice is just math. As you know, actuaries are determining underlying medical cost trends. They put that in the effective growth rate, and the math flows out in the rest of the advance notice from that.
Yeah, I think people overestimate the degree of discretion. There are methodological changes, of course, that have an impact, but that's super helpful. I've gotten a 10-minute warning or less, and there are a few things I want to do a lightning round if you'll sort of bear with me here.
Sounds good.
As I was in the job, I found that I was always navigating between certain tensions. So I got two or three or four tensions that I wanted to just get your reaction to, if you will, a sentence or two or three about each one. So one tension was always, do you save money for taxpayers? And doing that creates a bunch of new processes, a bunch of burden, a bunch of regulation. So unlike, a pure regulatory agency, there's this tension that government micromanagement actually saves money. So how do you feel about that tension? And do you experience it?
I'd say a couple of things. I don't believe that we believe we will achieve more savings by increasing government into central planning. I also think it's a false construct to think that there is or should be that tension between savings for taxpayers and more government micromanagement, regulation, or burden. To the
Helpful.
contrary, free the market to do what it does. Physicians got into the business in order to provide care. They took an oath to do that. Let them do that. Reward the people who provide the best care most cost efficiently. Stop rewarding people who have a PhD in policy, who are better at navigating the complexity of Byzantine rules and regulations that we're establishing. Now, many of those are good and wise and prudent. Our job is to keep people safe and healthy. And so we put rules in place to ensure that happens and that they get the care they need in a predictable and safe way so that they don't have to be looking over their shoulder. But sometimes some of those rules aren't. And that creates intermediaries that don't add value. As much as possible, we want to free the people who are building a long-term relationship with the patient to render the care that they know is what the patient needs and to give them the incentives to do so in the right way and in a responsible way.
How about the tension between saving money, so preventing ER visits, and sort of paternalistically telling people how to live? Maybe some people, like to eat Twinkies and, feel like that would be a good choice for them. And I know you've got the Maha, sort of approach here too. But at the end of the day, people
smoothie here right now. You can't.
Yeah, I got it. So people make their own choices. And so how do we sort of respect that, but also not have the taxpayer pay for things that aren't necessary.
Yeah, our goal is to pay for outcomes, as you know. That requires then to have empowered providers or physicians and other providers who are around them, empowered consumers to make choices, but who also have accountability. Sometimes that's missing in healthcare. And so, how do we create an incentive for a patient to want to make a better decision, to want to be a little bit healthier? And then, how do we align those incentives for payers as well? I think if we do that, and there are solutions to that, then there's no need for paternalism, especially if accountability exists at each one of those levels. I don't think that the government should become paternalistic. I don't think that's likely to lead to good outcomes. Quite to the contrary.
I got two more for you. One is the tension between breaking things because you want to run fast and driving change. If you break break the systems, the computer systems, you don't sort of things don't work right. You need time to implement. How do you manage that tension? That was a constant struggle for me too.
Stability matters. I'm curious how you thought about balancing that struggle, but stability and predictability matter. We often get caught up in the tax status of participants in healthcare and say, well, they're for profit or they're nonprofit, and if they're for profit, they must be evil. It turns out that that is a tax status. Most organizations are seeking to produce a profit. Why are they doing that? Well, in part because they have costs. Every person who works in healthcare seeks to achieve a paycheck. They want to be fairly compensated for the services that they're rendering. And so vilifying that is not constructive. That also means then you need capital flows in order for those participants to continue to participate in the market. But I would suggest that we are charged at CMS with serving only two stakeholders, and it's in this order. We serve our beneficiaries and we serve taxpayers. So we have to balance breaking things sometimes now in order to maintain long-term stability so that we don't break our country. And I feel that tension heavily. I suspect you felt that as well. It literally keeps me up at night. I worry about the fact that two-thirds of personal bankruptcies are a function of unsustainable medical debt. That's a problem. That's a moral failure. It's a market failure as well. We have to do better. At the same time, I worry for my children, for our grandchildren. I worry for today about a sector of the economy that's net negative productivity at 20%, growing 3% faster than GDP, breaking our country. That's a recipe for sovereign insolvency. And so we have to balance both. It turns out if you allow market forces to focus on outcomes, you compensate for outcomes, you require Medicare Advantage plans and other participants to produce outcomes, not a cost plus contract. They have to render results and they have to do that cost effectively. And you empower consumers to choose and to fail those and apply a failing grade, which means bankruptcy or going out of business for those who choose not to deliver great outcomes at a reasonable cost. We can solve this. We can get there. I genuinely believe we can rein in healthcare costs and we can certainly be healthier as a nation. Those are not impossible, intractable goals.
Chris, this has been a great conversation. We've come to the end of our time. I want to thank you on behalf of Paragon Health Institute and all of our audience for taking the time to answer questions, be part of this conversation. I want to thank you for your leadership of the Medicare program. I want to thank our audience for joining us today for this event. We had more than 1,000 people RSVP to talk about two obscure former and present government officials to share thoughts. The recording will be available tomorrow in case there's more of you. And we'd love to keep all of you informed about future events as well as updates from Paragon. And if you haven't already done so, I encourage you to visit our X account on social media or go to our website at paragoninstitute.org to sign up to receive our new weekly newsletter. So thank you all for joining, and thank you, Chris, in particular, and look forward to future collaborations and dialogue.
Thanks for all of your work, Demetrios. We're building on it, and I feel so grateful to you. And thanks for doing this as well. It's wonderful to be with you.